to be here today with you to discuss a new approach to communicating prevention needs to your patients. Motivational interviewing, or MI as we like to refer to it, is definitely coming of age. MI is a gentle form of counseling that is characterized as a collaborative conversation style. MI is a partnership that works by strengthening a person's own motivation and commitment to change or adherence to treatment. In the short time we're together today, I'm going to cover 4 key points. We're going to briefly discuss patient compliance, or what we like to call patient adherence. We will review the concept of readiness to change using the stages of change model. I will do my best to explain the spirit of motivational interviewing in an introductory manner, and will provide you with some examples of MI communication approaches which you should help in your patient interactions. My personal goal for today is to pique your interest in motivational interviewing and have you seek out additional resources on this topic, or better yet, attend motivational interviewing training. I think we can all agree that behavior change is not easy. I'm sure I'm not the only practitioner that has patients who do not comply or follow through on what has been recommended or advised. Before I studied motivational interviewing, I was more often than not frustrated by my patients who never changed their behavior. I simply did not understand why patients did not do what I recommended. This concern is nothing new to healthcare. Even Hippocrates described this centuries ago. We used to describe the lack of follow-through with recommendations or advice as a lack of patient compliance. It's been suggested that this term compliance represents a more authoritarian view. So today, it's been suggested that we use the term adherence, which represents a more collaborative approach. Either way, we know that globally, patient non-adherence can be a real threat to health and well-being, and it carries a substantial economic burden as well. In some disease conditions, more than 40% of patients have significant increased risks for further complications through misunderstanding, forgetting, or ignoring healthcare advice. We also know that adherence is poor in patients who have non-life-threatening chronic conditions such as those we currently treat in our dental offices. And it should come as no surprise that patients with good levels of oral hygiene tend to comply or adhere with our advice more often compared with those patients who have poor self-care. There are some documented disparities that have been shown to affect health behavior change. Those patients in lower socioeconomic groups tend to have less patient adherence. It has also been shown that oral health behavior is closely linked with other healthy lifestyle behavior, which means that our patients who do not smoke, who exercise regularly, who thoroughly clean their teeth every day, who follow a healthy diet, are the group that has better oral health and higher rates of patient adherence. The research literature on patient adherence is extensive. Over the past 60 years, there have been over 75,000 adherence-related citations in PubMed. Of these citations, more than 10,000 represent empirical research articles that involved the assessment of patients' adherence in a variety of health provider prescribed regimes like medication, diet, exercise, and lifestyle changes. Even when faced with acute illness, patient adherence rates are not ideal. And in dentistry, our rates have ranged from 16% to 55%, with the higher rates of adherence attributed to a closer follow-up on the part of the dental provider. I think we will agree there is room for improvement in this area, and today I hope to provide you with some strategies and approaches that you can apply tomorrow or next week that you could positively impact patient adherence in your practices. Our ability to connect with our patients is crucial to what we do as healthcare professionals, and it's also vital to helping our patients move towards healthy behavior change. The way we communicate with our patients can have a real effect on not on how they feel, but on what they do, but more importantly, on their health outcomes. Most of us have 3 basic communication skills that we use to interact with our patients. These would be asking, listening, and informing. Motivational interviewing combines these skills to guide behavior change. Guiding patients rather than directing them allows the patient to keep their autonomy and has been shown to enhance the commitment to change as well as the adherence to recommended treatments. Motivational interviewing really uses skills that we already use on a regular basis in a strategic way to help patients commit to change. Now, before we take a deeper look into motivational interviewing, I do want to discuss our patients' readiness to change. As healthcare providers, we know that patients differ in their readiness to change. And change is not easy. Just look at yourself. I can look at myself and know that change is not easy. Our patients have mixed feelings and thoughts about it. The most common place to get stuck on the road to change is ambivalence. Ambivalence is not denial. Patients see both reasons to change and reasons not to change. They want to change. They don't want to change, all at the same time. Resolving ambivalence is the central aim of motivational interviewing. In addition, change is not linear. Patients don't move in straight lines from non-change to change. In many cases, initial steps towards change occur, setbacks happen, and sometimes even a return to old behaviors happens before change is actually accomplished. The trans-theoretical model of health behavior change, that's a mouthful, right? Or the stages of change model, as we like to call it, was created over 25 years ago and was first applied to smoking cessation therapy. This theory purports that change is a process involving progress through a series of stages that begins with disinterest to maintenance of that behavior change. People progress through different stages on their way to successful change. And it's important to accept that each person is unique in this process and will move through these stages at their own rate. So here are the 5 stages. The first stage is pre-contemplation, or not ready. Contemplation, getting ready. Preparation, ready to change, but not change. Action, doing the behavior change. And maintenance, sustaining the behavior change. Now, the critical assumption that underpins this model is that behavioral changes don't happen in one step, but through a series of distinct, predictable stages. Realizing the stage of change your patient is in will be helpful in your communication approach. In other words, your approach with a patient who is not ready for change should be different than your approach with a patient who is ready for change. Let's talk a little bit about the first stage. People in this stage don't want to make changes to their habits, or they don't recognize they have a problem. They may be pessimistic about their ability to make a change, or even deny the negative effects of their existing lifestyle habits. People tend to defend their current bad habits in this stage, and oftentimes they selectively filter information that helps confirm their decision to not change, to not eat better, to not brush regularly. They may be defensive in the face of other people pressuring them to quit or stop the bad habit. Sometimes they refer to this stage as the denial stage. Here are some examples of what pre-contemplation might look in the dental office. Now, this stage is really difficult because we have to help the patient overcome what is holding them back from making a change. In some cases, we have to be skillful in providing the patient with enough information in a non-confrontational manner to move them to the next stage where they can really begin to consider change. So here we are in contemplation. During this stage, your patient is really the costs and the benefits of modifying their lifestyle. They're thinking about the effort, the time, the finances that it will take to change their current bad habit. They're asking themselves whether it's something that will be worth it. Interestingly, in this stage, people can remain for years without preparing to take action. Now, on the plus side, people are more open to receiving information about their bad habit and more likely to actually use educational interventions and reflect on their own feelings and thoughts concerning the bad habit during this stage. That's good news for us. Here are some examples of contemplation. Ambivalence reigns in this stage. And as a healthcare provider committed to helping to make a difference in the lives of our patients, our role will be to help them overcome ambivalence so behavior change can happen. People in the preparation stage have decided to change their negative habits, usually within the next month. This is also called the determination stage. Patients may say to you, "I've got to do something about this. This is serious. Something has to change. What can I do?" Here are some examples. It will be important for us to continue to motivate the patient to make that final commitment to change. Ambivalence can still be present in this stage, but not at the same level as earlier stage. The action stage is the process of changing the lifestyle or the habit. This is also called the willpower stage. The actual time spent in this stage really varies from individual to individual, but generally they say it lasts about 6 months. Patients in this stage are at the greatest risk of relapse, so it's key to help the patient stay motivated through coaching and encouraging the patient. Here are some examples of action. In this stage, mentally, patients are reviewing their commitment to themselves, and they're developing plans to deal with personal and external pressures that could lead them to a relapse or a slip. They might even use short-term rewards to sustain their motivation. They definitely analyze their behavior change efforts in a way that enhances their self-confidence. People in this stage also tend to be open to receiving help and are also likely to seek support from others, which is a really important element and a real opportunity for us. The fifth stage of change is the one that we hope all of our patients realize. This is the stage of sustained lifestyle modification. The patient has blended positive habits into their lifestyle and has been able to successfully avoid any temptations to return to the bad habit. Our role is to recognize and affirm the success of our patients in this stage. We want to maintain this new status quo. Another stage that is often referred to as the sixth stage of change is relapse or slip. It is important for us as healthcare providers to realize that this stage is a normal part of change. If the patient slips or relapses, they could feel like a failure, which could prevent them from returning to the action stage where they were actively participating in their behavior change. A slip is considered to be less serious than a relapse. Now, granted, both events are negative, but they do differ in the degree of impact that it will have on the life of the individual. An example of a slip would be a patient who has, let's say, stopped smoking and for whatever reason picked up a cigarette and smoked one. With a slip, the patient recognized right away what a huge mistake that was and got right back into their non-smoking lifestyle. Unlike relapse, a slip is merely a very brief setback. Now, if relapse happens, the patient could return to a point prior to the action stage of change. And the dental professional should help the patient understand the triggers that led to the relapse, to recognize the barriers that exist which get in the way of their success, and take steps to help the patient overcome these obstacles. And finally, engage the patient in reaffirming their goals and their commitment to change. It's also important for us to remember that relapse or slip is normal, and it's natural to regress, to attain one stage only to fall back to a previous stage. It's just a normal part of making changes in behavior. So this is what the stages of change model looks like. You can see where we can move from pre-contemplation to contemplation to preparation to action and finally to maintenance. And at any point, we can fall back. And at any point, we can have a slip or a relapse. Patients often feel ambivalent to change, especially when change is good for them. In some cases, such as a patient who's trying to add interproximal cleaning in their daily routine, change could be uncomfortable or even painful. People do and can get stuck in ambivalence. And it's important for us to recognize that ambivalence is very common in this pre-contemplation, contemplation, and even preparation stages. And this is where motivational interviewing can make a real difference. Before we leave the stages of change model, I would like to have you identify the stage of change that a patient may be in. This is a case that's been adapted from a case that was written by Dr. Philip Weinstein in his 2002 Motivate Your Dental Patients workbook. I'd like you to meet Mila and her mom, Miranda. Mila's nearly 3 years old. She was brought in by her worried mother for a second opinion because of at least 4 soft brown spots on her maxillary incisors, along with several white spot lesions on the cervical 1/3 of 6 other teeth. Mila's mom says she and her husband are very health conscious, only eating homegrown organic foods, limiting their processing foods, including sugar. Now, Mila is still breastfeeding upon demand, and Mom commented to you on how important breastfeeding was to Mila's immune system, and more importantly, how important it was to her emotional well-being as a parent. And she's pregnant again. Mila's mom and dad are very upset when they learn from their first dental visit that Mila has early childhood caries and that general anesthesia in a hospital setting was recommended. Miranda tells you that she has searched the internet to find alternatives to treatment for Mila and is not sure that anything really needs to be done at this time. Now, because Mila is a young child, you would want to identify the stage of change that her mother is in. So related to restorative care for Mila, what stage would you place Mila's mom? Is Miranda in a pre-contemplative stage, a contemplative stage, a preparation stage, an action stage? If you guessed contemplative, I would agree. because clearly mom is accepting that some sort of treatment needs to be done, but she's not sure if it needs to be done at this time. Now, what stage would you feel mom is regarding stopping breastfeeding? If you said pre-contemplative, I would agree, because mom has no idea that the breastfeeding could be contributing to the early childhood caries seen in Mila, and she has defended this by telling you that it positively impacts her own emotional well-being as a mother. Knowing this, what would you say or do to get the patient to go to the next stage? This is where the communication approaches used in motivational interviewing may be helpful to you. The term motivational interviewing was first coined by U.S. psychologist Professor William Miller in 1983, and it evolved from his experience supporting problem drinkers. In the early 1990s, the fundamental concepts of motivational interviewing were further elaborated by Miller and another psychologist from the UK, Professor Stephen Rolnick. From the 1990s onward, this method gained momentum. It was initially used as a counseling approach to support people to reduce their use of alcohol, tobacco, or drugs. However, it has since been applied to a wide range of behavior changes, from weight loss, exercise, managing long-term conditions like diabetes, pain management, anxiety, and depression, and other issues where behavior change and self-confidence is desired. The term motivational interviewing is usually associated with the healthcare sector, although broader coaching approaches have been used in human resources, management, and even leadership development, and even to a limited extent in education and criminal justice sectors. Drs. Miller and Rolnick have written a text on MI. Their first edition was published in 1991, the second edition in 2002, and the third edition this year, 2013. Today, there are over 25,000 articles citing MI and over 200 randomized controlled trials of MI on a variety of topics, including a handful in dentistry. Both Dr. Millers and Rolnick have conducted workshops, and if you're lucky enough to ever attend an event where they're speaking, I would highly recommend it. Motivational interviewing draws on people's intrinsic motivation to change their behavior and improve their health. According to its authors, it is first and foremost a conversation about change. MI can be brief or prolonged. It can work with individuals or groups, but it is always collaborative. In their newest edition on motivational interviewing, Miller and Rolnick have changed their approach slightly and described 4 broad processes that comprise MI. These processes form the flow, and the authors believe that by promoting the 4-process model, it will help to clarify how MI actually unfolds in practice. So engaging is the process by which both parties establish a useful or helpful connection and a working relationship. Sometimes this occurs within seconds. Sometimes it takes weeks or multiple appointments to establish rapport and a connection that is so fundamental to everything that follows. Focusing is the process by which you develop and maintain a very specific direction in the conversation about change. This helps to clarify the direction towards one or more change goals for the patient. Evoking is the process that involves eliciting the patient's own motivation for change and is the heart and soul of MI. Evoking is having the patient voice the arguments for change rather than you. If the patient hears themselves talking about change, they're more apt to change. Therefore, your task is to elicit this change talk from your patients rather than resistance. Planning is the process that encompasses both developing commitment to change and formulating a very specific plan of action. It is a conversation about action. Because this is just an introduction to motivational interviewing, today we will concentrate on engaging and evoking. MI really can't be successful without good communication skills. One of the first tips I learned when I attended a workshop on MI is to ask permission first. Although it can be implied that the patient in your dental chair is there to receive information from you, I have found that by asking permission to speak with the patient about your findings, it positively impacts your rapport. This doesn't need to be really formal. It can be a simple yes or no question, but just be sure your patient understands what you're asking. You could say, "Is it okay with you if I share some concerns? Would it be okay if we discuss what I found when I measured your pockets? Do you mind if we talk for just a bit about some areas of concern in your mouth?" Although they represent two different tools in communication, asking and listening fit naturally together and complement each other. When talking with your patient, you don't want to overwhelm them with information. And most importantly, you want to use reflective listening. Reflective listening is a skill that engages others with an authentic communication exchange. It builds trust, relationship, and really impacts the desire to change. Reflective listening seems simple, but it's quite tricky. It involves repeating, rephrasing, and/or paraphrasing, as well as reflecting on feeling or emotional statements. I think for most of us, asking questions is much easier than listening and then reflecting back to the patient what was heard. If you concentrate on this one skill of reflecting listening, you will have a tremendous gift to give to others. It's critical that you seek to understand the patient's message, which includes using empathy to see the world through the eyes of the patient. It involves the ability to understand another's frame of reference. Sometimes part of listening is hearing what the patient is not saying. In addition, MI involves listening for and appreciating the patient's ambivalence about change. One key to listening for ambivalence is the but in the middle of a sentence. Your patient might say, "I'd like to make that change, but..." Our goal as careful listeners is to selectively reinforce the patient's speech that is in the direction of change or leaning towards change. There are 5 methods that are useful throughout the process of motivational interviewing. The first 4, summarized by the acronym OARS, O-A-R-S, which stand for open-ended questions, affirmations, reflections, and summarizing, come from client-centered counseling. These 4 skills may not be new to many of you because you already use them in your communication with others. In motivational interviewing, they are used to explore ambivalence or uncertainty and clarify reasons for change. The 5th method, eliciting change talk, which is the +E, is more directive. It integrates and guides the use of the other 4 methods. Although these 5 methods appear quite simple, they're not always easy to use, and quite honestly, they do require considerable practice. The O in OARS stands for open-ended questions. Open-ended questions encourage people to talk about whatever is important to them. They help build a relationship, gather information. They increase understanding. Open-ended questions ask for more information about the subject. Closed-ended questions are the opposite. They are questions which require only a limited response, like yes or no. And they provide only a limited amount of knowledge to you as the interviewer. Now, it's important to know, I'm not saying that closed-ended questions cannot and should not be used. There is a place for closed-ended questions. But open-ended questions invite people to tell their own stories in their own words from their own points of view. And I'm always amazed at the richness of content that goes far beyond the mere facts, that allows me to hear what makes that person tick. Open-ended questions should be used frequently in conversations with your patients. Now, in the case of Mila and her mom, Miranda, if you wanted to gain more information about Mila's oral care at home, what might you ask? Now, knowing what you know about open-ended questions, I don't expect you to ask the obvious, do you brush Mila's teeth? Because that's a yes or no question. But instead of asking something like, how often do you brush Mila's teeth? You might approach it with, tell me more about your toothbrushing routine with Mila. This would provide you with a lot more information and a lot less follow-up questions. In the case of reluctance of Mila's parents in having the restorative work completed, you might ask, what worries you about treating the cavities in Mila's teeth? This would provide you with a lot of information and give you a little bit more perspective of what her parents are thinking. Other open-ended questions that I like to use include, tell me about your teeth. What difficulties have you had? What do you want for your dental health? Would you help me understand? How would you like things to be different? How would you like things to be better if you changed? How can we help to make things better? What do you think you will lose if you give up, say, smoking? The A in OARS stands for affirmations. MI attempts to build patient feelings of empowerment and self-efficacy. Affirmations are statements of appreciation for the patient and his or her strengths. Affirmations are not compliments. Affirmations usually take the form of very clear and genuine words of understanding and appreciation. They build self-confidence in the patient's belief that he or she can change. They don't have a particular structure. However, they should always be positively stated. Focus on a strength or an attribute, not on a lack of something. Also, affirmations should not begin with I statements, such as, I am so proud of you, because these focus more on you than on the patient. Something like, you're amazing, you're so impressive, would be a better approach. With regard to Mila and her mom, a simple affirmation could be, you have done your homework with regard to researching treatment options for Mila. Or, your resourcefulness is impressive. Or, you're to be admired for wanting to have the best possible care for Mila. Other very simple affirmations that you could use tomorrow or next week is, thanks for coming in today, and even arriving early. You really tried hard these past 3 months with your home care. You really know what works for you when it comes to keeping your mouth clean. R stands for reflections. To prove that you've actively listened, heard, and understood your patient, you reflect back to the patient a short statement of what your patient just said. By doing this, it allows your patient to clarify what he or she said. And when the patient clarifies after you've offered a reflection, they may begin to speak about change. I had mentioned earlier that reflective listening can be tricky. In order to master the skills of reflective listening, consistent practice is necessary. It really requires listening to what the patient is saying, responding back to the patient to ensure understanding of what the patient's just said, and to clarify. I figured out early on that after I listened for a while, I needed to make a decision, because patients provide you with so much rich information, you cannot begin to reflect on it all. And this is where you as a practitioner needs to set an agenda as to the direction your conversation will go. Reflections are similar to questions, but the delivery is different. All reflections are statements. For example, a reflection might be, you are feeling anxious about this. Notice how my voice inflected down at the end. This was a statement that clarified what the patient just told me. A question would be, You're feeling anxious about this? Hear how my voice inflected up at the end. This is a question and not a reflection. A patient is more apt to elaborate with a reflective statement rather than a closed question. There are many, many types of reflections, but two common ones are simple and complex. With a simple reflection, you can use some of the patient's words in your statement, but be careful not to mimic the patient. You could substitute some synonyms or slightly rephrase what your patient said. You could say, so you feel, and then repeat what the patient said. It sounds like you're wondering if, so what I hear you saying is, please correct me if I'm wrong. This is what I'm hearing you say. So let's see what a simple reflection might look like for Mila and her mom, Miranda. Let's say that in the course of your conversation with Miranda, she says something like, I have spent hours searching the internet to learn more about this early childhood caries and how it's treated. I'm not sure I buy into the need to do general anesthesia. It sounds like overkill to me. I want to do what is best for my little girl, and to top it all off, my husband and I don't agree on which way to go. Wow. Miranda has provided you with quite a bit of information, and at this time, you need to make a decision as to what direction you want the conversation to go. Do you focus on Miranda's feelings, on the uneasiness surrounding general anesthesia, or the conflicts between her and her husband? This is a decision that you must make. For a simple reflection, you might say something as simple as, you're not sure. This allows Miranda to provide you with more information. Now, complex reflections bump it up a notch and can be used to add to the patient's self-understanding. Complex reflections may help patients consider elements that they hadn't considered before. Many times with complex reflections, you can emphasize the emotional dimension of what's happening with the patient. So for Miranda, a complex reflection to her telling you that she's not sure about the need for general anesthesia could be, you're worried about general anesthesia for Mila. This complex reflection then moves the conversation into a different direction. A tip about reflections. For every question that you ask, you should try to offer at least 2 reflections. This will build momentum in your conversation. Summaries are effective and gentle ways of bringing reflective listening to a close. At some point, you need to stop the conversation. You can summarize what you've understood and suggest a change in direction. You will want to be honest about your time limitations. Always acknowledge the value of what you have heard. Summaries can also be used from one focus to another. By offering a summary, it allows the patient to hear what was said. Summaries are several reflections pulled together. A summary begins with a statement that lets your patient know you're making a summary. You could say something like, let me see if I understood. And then you would proceed with your summary statements. When ambivalence is present, you can address it with a double-sided statement. So what I heard you say is, on one hand, you want to make sure that Mila gets the best possible care in the treatment of her cavities, and on the other hand, you're concerned that placing her in the hospital and using general anesthesia is not necessarily the best way to go. You can end the summary with another question, which then shifts the focus to another direction. Something like, if that is accurate, what other points should be considered? Or you can end the summary with an invitation, such as, did I miss anything? Anything you want to add or correct? After the patient clarifies, you can simply ask, what are the next steps? Then you and your patient can get busy setting some goals. We've spoken about ORs as some core skills involved in engaging our patients. And I now want to elaborate on the evoking process, which includes helping your patients to talk about change. Remember, at the heart of MI is letting the patient tell you about change rather than you, as the healthcare professional, telling the patient they need to change. During our listening, we should always be on the lookout for change talk. So what is change talk? When listening to a patient, there are 6 different themes you may hear about behavior change, and your job is to listen for these themes. They're listed here with the acronym DARN CAT. You'll be listening for verbs. So if a patient says to you, I want to get rid of this gum disease, you're hearing desire or preference for change. If the patient says, I might be able to cut back on my soda, or I can cut back on my soda, you're hearing ability. If your patient says, I would probably feel better if I stopped smoking, you're hearing reasons or arguments for change. If you hear, I really should use that special toothpaste you gave me last time I was here, you're hearing need or the feeling of obligation to change. It's important to note that with all of these, there are different levels of confidence. So a statement like, I might be able to, compared to I can, has very different levels of confidence. And your approach with your patient needs to reflect that. If you have a patient that's not confident about change, you need to approach that with encouragement and coaching to help them realize that they do have the ability to change. Now, commitment and taking steps talks about, well, it actually means that they're moving towards change or action. Commitment might sound like, I'm going to, or I intend to. And taking steps sounds like, this week I started flossing, or I actually went out and bought some nicotine patches. At the same time you're listening for change talk, you also want to elicit change talk by asking questions using desire, ability, reasons, and need. If you ask a desire question, your patient should respond with desire change talk. Listening for change talk and eliciting change talk is a presentation all of itself. And if you're interested in learning more about this, I will provide you with some resources in just a moment. So now that you have been exposed to that darn cat, besides asking appropriate questions, what are some other methods you can use to evoke change talk? I like to use the readiness ruler approach. Using a scale is not uncommon for many of us. I often use a scale when I ask my patients to describe what level of pain are they at. This is similar. To gauge where your patient falls with regard to, say, how important it is to make a change, or their desire to make a change, or their confidence to make a change, you can use the readiness ruler. So let me demonstrate with importance. You have a patient and you're discussing importance. And you ask your patient, how do you feel at this moment about this behavior change? And they'll answer. And then you will say, how important it is for you to make this change. On a scale of 1 to 10, where 1 is not at all important and 10 is extremely important, how important is it for you to make the change? And your patient should give you a number. Let's say the patient gives you the number 6. The very next question should be, why is it a 6 and not a 3? By asking this question, always going down in the number scale, your patient will begin to talk about why it is important to change. After hearing the patient's response, you could ask, what would need to happen for you to go from a 6 to an 8? This should elicit more change talk and more clarity as to why they aren't at a higher level on the importance scale. And finally, you can ask, how can I assist you in getting to an 8? Tips in using this ruler. If the patient gives you low numbers, say 1 through 3, they're probably at a very low level of importance or desire or confidence. The middle gives you kind of a moderate middle level, and then if they score from 8 to 10, they're probably thinking it's very important or have a higher desire or a high confidence to change. It's important to know where they stand, because if you have a patient who tells you that they're at a 10 for importance but a 3 for confidence, you need to approach them in a different way. You need to build their confidence because they already feel the importance of change. This is something that I hope you can take with you and just do. And obviously, you don't need a real ruler to do this. Your patients will understand the scale from 1 to 10. Well, we've come to that time now where hopefully you have understood that relationship between motivational interviewing and stages of change. I hope I've done a good job of explaining the value of using some of these principles of motivational interviewing in your patient communication. I hope that you've been able to take away some new approaches to help your patients overcome ambivalence and change. And most importantly, I hope I stimulated an interest for you to learn more about motivational interviewing. There are many resources on the market, and here are but a few. I would highly recommend the 2 books on the lower left for introductory information on motivational interviewing. These are excellent books. Also, I would recommend www.motivationalinterviewing.org. This is a great website. It has so many resources on MI and even gives you MI trainers if you were interested in going and attending training in motivational interviewing. I would like to thank you at this time for staying with me and hearing about how motivational interviewing approaches could impact your patient communication. And I'd like to close with a really beautiful MI prayer that was written by Dr. Miller. He lives in the American Southwest, and this is what he says. I've often had the privilege to talk with Native American providers about motivational interviewing. Some have told me that this respectful way of leading and relating to others is quite compatible with tribal conversational norms. A tribal leader once observed, however, that in order to teach MI to American Indians, it should have a prayer, a song, a dance. I leave the dance and song to more capable people, but I did craft this prayer with the help of Raymond Daw. This particular version reflects meditative preparation to work with a female client, but the pronouns can easily be changed. And here it is. Guide me to be a patient companion, to listen with a heart as open as the sky. Grant me vision to see through her eyes and eager ears to hear her story. Create a safe and open mesa on which we may walk together. Make me a clear pool in which she may reflect. Guide me to find in her your beauty and wisdom, knowing your desire for her to be in harmony, healthy, loving, and strong. Let me honor and respect her choosing of her own path and bless her to walk it freely. May I know once again that although she and I are different, yet there is a peaceful place where we are one. Thank you.